was having trouble with the clicker. I'm fine using the laptop if we need to, but I'll just operate off the laptop.
Okay.
All right, so let's go ahead and get started. Hi everybody, I'm Taylor Preston. I'm a psychiatrist from UAB School of Medicine. Glad to be back here with y'all at St. Vincent's East. This time we'll be talking about anxiety disorders. I do plan to have some interactive content for those of y'all that are in the room with me here at St. Vincent's East. So stay tuned and be ready to participate. It's much more fun that way and hopefully more beneficial to everyone. I have no conflicts of interest to disclose. I'm but a humble med school professor. So I think it's important that we first start out talking about what anxiety is before we go into anxiety disorders. So anxiety is a subjective experience of fear and its physical manifestations. So some of these symptoms include symptoms of sympathetic activation, so heart palpitations, shortness of breath, sweating, but there's some other perceptual disturbances, GI disturbances, choking sensations, trembling, and don't forget that some anxiety can be a common normal response to a perceived threat. If a bear is chasing you and you don't feel anxious, there is something wrong with you. And I always tell my students, are we not on over here? Is it on the live stream or on the in-room?
It's on the line.
Let's see. We're good? Can you hear?
Yeah, we're good.
Okay. So I always tell my students that a little anxiety before the big exam is actually healthy because it pushes you to keep studying, but if the anxiety is so severe that it cripples you, you can't focus, you can't get anything done, then that may be a problem that we need to address clinically. So in pathological anxiety, symptoms interfere with daily life and interpersonal relationships. So for those of y'all that have studied the DSM, our diagnosis Bible from psychiatry, you might remember that one of the final lines in every diagnosis is the symptoms must interfere with social or occupational functioning. So there's no disorder if there's no dysfunction. So always remember that when you're making any kind of mental health diagnosis. It's also important to note that anxiety disorders are the most prevalent type of psychiatric disorder. So that means that those of y'all who are not necessarily mental health professionals, but primary care professionals and healthcare professionals throughout the clinical world are going to see anxiety disorders. So the first category we're going to talk about is panic attacks. Notice I say panic attack and not panic disorder. I'm going to circle back around and talk about panic disorder in just a moment. But first I want to make sure we all know what a panic attack is. A discrete period of intense fear and discomfort in which 4 or more of the following symptoms develop abruptly. So some of these again are sympathetic manifestations, so increased heart rate, sweating, shortness of breath, but they can also be other somatic symptoms such as nausea, trembling, lightheadedness. There's also depersonalization and derealization. In case y'all forgotten what those are, I imagine you don't encounter those on a daily basis. Depersonalization is an out-of-body experience where you perceive that you're outside of your body looking down upon your body. And derealization, just the feeling that what's going on right now is not real. There are also some cognitive disturbances here. So I feel like I'm losing control or going crazy or possibly I'm dying. And then numbness, tingling, and hot flushes or chills. One more note about panic attacks. A panic attack by its very nature needs to be an acute crescendo, decrescendo of symptoms. The DSM doesn't actually specify the duration of a panic attack, but just from clinical experience, it tends to be about 5 to 30 minutes. I've had patients before tell me, I've been having this panic attack for the past 3 days. If they're having a panic attack for the past 3 days, it's probably not a panic attack, and we need to reevaluate what the most accurate diagnosis is. So now we move on to panic disorder. And I mentioned before that panic attacks and panic disorder are 2 different things. So a panic attack actually can be found with a number of different diagnoses. You can have generalized anxiety disorder with panic attacks or post-traumatic stress disorder with panic attacks. For it to be panic disorder, it has to be recurrent, unexpected panic attacks with at least one of the attacks has been followed by a month or more of the following. Persistent concern about having additional attacks, worry about the implications of the attack, or significant change in behavior related to the attacks. And so what this looks like is a person has a few panic attacks out of the blue. it's terrifying, and they're so afraid that they're going to go into a crowded situation, such as a classroom, a meeting at work, a crowded concert or a church setting, and that they might have an unprovoked panic attack, and it will be terrifying because they'll feel trapped. When a person has a panic attack, their first instinct is to run and get to a place of relative safety to them. And for that reason, panic disorder commonly coexists with agoraphobia. So for those of you that learned, that took your psychology and psychiatry classes around the same time I did, you might have learned from DSM-4, which was the active manual until 2013. And in that edition, they actually specified you had to say panic disorder with or without agoraphobia, because about 70 to 80% of panic disorder cases also came with this side of agoraphobia. DSM-5, our new book that has become the active edition effective in 2013, separated the two out. But it's still important for you to understand what panic disorder feels like and why it is attached to agoraphobia so closely. So again, agoraphobia is a fear of being in places or situations from which escape might be difficult. I have almost always seen agoraphobia coexisting with panic disorder. I very rarely see it as an isolated diagnosis. So I'm not going to go too much further into agoraphobia here. It's important to note common triggers of panic disorder because we commonly forget to ask about these things. We've all been trained in our various healthcare professional programs to ask about tobacco usage, but we forget to tie that to anxiety symptoms. We forget nicotine actually is a sympathomimetic and can make people feel more anxious. Likewise, we rarely ask about caffeine in a good social history. I've so many times had a patient complaining about their panic attacks, and I find out that they drink a pot of coffee a day, and you can imagine that that might make things much, much worse. So a good, thorough social and medical history is crucial. We also need to rule out medical conditions. Anybody want to throw out a couple of medical conditions that sound like they might trigger some panic-like symptoms? A heart arrhythmia, absolutely, that's a great one. Supraventricular tachycardia is actually more common than you might think. Anything else? This is where the medical students always throw out pheochromocytoma. It's always a fun one to learn about, but I never actually find it. Still waiting for that one so I can write it up in a journal. Some other common ones. Any ER docs here? Okay. What comes into the emergency room a lot? Yeah, so chest pain. So we have to rule out acute coronary syndrome, pulmonary embolism, asthma exacerbations. You never want to be that physician or other provider that sees in the patient's history that they have a psychiatric history. Oh, this must be panic disorder. We don't need to do a cardiac workup. You always still want to be thorough in ruling out medical conditions that might masquerade as psychiatric symptoms. Substance intoxication. What are some fairly common intoxications that might look like panic symptoms? Cocaine and methamphetamine, absolutely. And sometimes I've even seen people misuse prescription amphetamines. So the drug commonly known as Adderall is mixed amphetamine salts, and when people misuse that, it could mimic panic symptoms. What about substance withdrawal? There are two different kinds that actually can be dangerous. Alcohol withdrawal, absolutely. And benzodiazepine withdrawal, absolutely. So we still need to keep our medical hats on and consider all the thorough differential diagnosis before we reach a conclusion that somebody has panic disorder. As far as treatments, SSRIs, the selective serotonin reuptake inhibitors that most of us are familiar with, paroxetine, sertraline, fluoxetine, are all reasonable choices. It's important to note that you often will need higher doses of SSRIs to treat panic disorder relative to the doses you might be used to seeing in depression. So a lot of times when I get a patient with panic disorder referred to psychiatry clinic where the primary doc has tried a couple of different SSRIs, what we'll find is, well, they've had a couple of trials, but they may not have been adequate trials. They might have tried the starting dosage of one of the SSRIs, like 20 of fluoxetine or 50 of sertraline. My record for sertraline, also known as Zoloft, is 300. which is not that uncommon in patients with really severe panic disorder. We can also consider acute initial treatment with benzodiazepines while we're awaiting the effect of an SSRI. Both clonazepam and alprazolam, that's trade names Klonopin and Xanax, have FDA indications for panic disorder. But we do have to be cautious with these because of their high risk for substance abuse. Personally, if I'm going to use a benzodiazepine, I much prefer clonazepam because of its longer half-life. With alprazolam, it's so short-acting that people commonly have withdrawal anxiety symptoms between doses, even dosed 3 or 4 times a day. Some clinicians will also use beta blockers such as propranolol to dampen that sympathetic activation that comes with panic attacks. But while that does have evidence in the literature, it doesn't have a formal FDA indication for that. Also, like to mention the role of psychotherapy, so cognitive behavioral therapy. Specifically, exposure therapy is used by many behaviorally oriented psychologists. And so what some clinicians will do is they'll actually have the patient run up and down in place or run up and down the stairs to mimic the effects of a panic attack. And by enough exposures, you actually extinguish the fear response that causes the panic attack. And also, with the exposure therapy, they also work in some breathing and relaxation exercises to help teach the patient how to slow down or arrest those physical symptoms associated with panic attacks. Okay. Any questions about panic before we move on? All right, well, let's move on. So now we're going to talk about phobias. So in general, phobias are an irrational fear that leads to avoidance of the feared object or situation. And then we subdivide that into 2 different subtypes, specific phobia and social phobia. So specific phobias are a strong, exaggerated fear of a specific object or situation. Most common types of that would be fear of heights, fear of flying. A smart aleck medical student will sometimes bring up fear of clowns. Never actually had a patient present with that. But you get the idea that these are very specific objects and situations. We also have social phobia, which is a fear of social situations in which embarrassment can occur. And I want to make sure we contrast social phobia with agoraphobia because that can be kind of confusing for some clinicians. Agoraphobia is the fear that you're going to be in a crowded place and escape will be difficult. Social phobia, on the other hand, is the fear that they're going to be embarrassed or scrutinized. For specific phobia, it's important to note they actually rarely show up in general psychiatry clinic. Why? Because they can usually just avoid the feared stimulus. If somebody is afraid of snakes, they avoid snakes. If someone is afraid of heights, they do their best to avoid heights. But every once in a while, somebody will have a fear of something that becomes impossible to avoid. Somebody who fears flying, who gets a great opportunity in a new job, but they have to travel a lot, and so it becomes an obstacle for them. Somebody that gets a new job on the top story of a skyscraper that only has glass elevators, they might decide they need to do something about this. So exposure to the situation or object brings about immediate anxiety response, such as a panic attack. Patient has to recognize that the fear is excessive and it interferes with the patient's functioning. Social phobia, I already mentioned, is a fear about social situations in which scrutiny can occur. And then we can further subdivide that into a couple of different flavors. So there are some people with a social phobia that is specific to public speaking, which can be kind of counterintuitive because people would think, public speaking, that's very specific. Let's call it a specific phobia. But it actually is a social phobia because at the root of it is the fear that I'm going to be embarrassed or scrutinized. And the other flavor of social phobia is a more generalized social phobia. So somebody avoids all common situations. So they start avoiding class, they start avoiding church, they start avoiding meetings at work, and that can become very impairing because it's hard to navigate life afraid of all social situations. As far as therapies go, the gold standard for any kind of phobia is exposure therapy with a subtype of systematic desensitization. So if somebody is afraid of spiders, we might start out by showing them a picture of a spider. Then we might show them a spider in a cage. Then we might show them a spider across the room crawling around. Then we might have them hold the spider in their hand. And if we were really, really ambitious, we might, throw them in a room full of spiders, but they probably will have quit therapy by that time. But you get the idea that we're gradually introducing the stimulus in a graded exposure. You can use benzodiazepines in a limited role with specific phobias, although there are no meds that have robust evidence or an FDA indication. A good example of using a benzodiazepine for specific phobia would be somebody with a flying phobia. That's actually a really good time for it because that's a good time to fall asleep if you have a long flight. So there are a few patients that I will prescribe 6 tabs a year of clonazepam for just for flying. Beta blockers such as propranolol can be effective for the public speaking subtype of social phobia. Again, it's off-label, but there is robust evidence in the literature for that. Social phobia does have a number of meds that have a formal FDA indication: paroxetine, sertraline, fluvoxamine extended release, and also the SNRI, venlafaxine XR. Let's see. I'm going to see if this video works. We're going to transition to obsessive-compulsive disorder next. Is this connected to the web? Never mind. Okay, we're not going to do the video. Uh-oh. Sorry about that. We're just going to pull it back up. See if we can, is that slideshow? Cool. All right, sorry about that. I got overly ambitious and tried to share a video. I'll tell you a little bit about the case because I think it helps illustrate what obsessive-compulsive disorder really looks like. It's this nice lady describing how when she pours drinks of water for company at her house, she has this overwhelming feeling that the drinks are poisoned, and so she has to taste them to make sure she doesn't poison somebody. But after she's tasted them, she can't very well give them to somebody else. So she has to start over, put them in the dirty dishes, and start with a new cup. She realizes that this is unreasonable. There's no way these drinks have been poisoned because she just poured them herself. But she is nonetheless overwhelmed with this fear that something bad has happened to these drinks. So in this case, the obsession would be the drinks are poison. The compulsion would be that she has to taste them. And that's the most common pattern we see in obsessive-compulsive disorder. This overwhelming tension that comes from an obsession and a temporary catharsis that comes with carrying out the compulsion. It's important to note that the person is aware that the obsessions and compulsions are unreasonable and excessive. So if she thought, these drinks very well could have been poisoned in the time between me pouring them and me tasting them. If she really thought that somebody was coming in and putting poison in them, or there were some little aliens that were coming by and putting poison in the drinks, that would be what we call a delusion. That'd be part of a psychotic disorder. In other words, a break with reality. People with OCD realize that these thoughts are unreasonable and excessive and are very distressed by having these thoughts. In other words, they're ego dystonic. The thoughts clash with what the person really knows and believes. And the reason I always bring up this term ego dystonic is how it contrasts with another disorder by a very similar name, obsessive-compulsive personality disorder. Anybody recognize that term? The way OCPD, obsessive-compulsive personality, was described to me in medical school, the instructor said, statistically, about 3% of y'all probably have OCD. But about 90% of y'all probably have OCPD. So people with obsessive-compulsive personality disorder tend to be actually pretty successful, high-functioning people, but they're really, really rigid and don't like anybody else interfering with their way of doing things. And so, medical students, lawyers, other high-functioning professional types have a high incidence of OCPD. I think she was probably speaking with a little bit of hyperbole. It's probably not 90%, but there are certainly a lot, and all the med students usually chuckle a bit when I throw out that stat to them, because they're looking around the room and identifying their peers like, yeah, you're definitely an obsessive-compulsive personality. Back to the point about the symptoms must cause marked distress and are time-consuming. One of the questions I always ask a patient when I'm trying to evaluate for OCD is, how much time do you spend on this? Because that gives you a great insight into how disturbing this really is. If they say, I spend 3 hours a day on this, that makes it really hard to get your other functions complete. If they say, well, I check the stove twice in the morning before I leave, that might be a little neurotic or quirky, but I think it's important we not go labeling people just because maybe they're a little more neurotic than others. So we really want to evaluate for the level of impairment. Some common patterns: contamination, so that would be like our lady in the clinical example I gave. Doubt, that would be people who check things more frequently. Symmetry, things that you might have to have the same number of objects on one side of your desk as on the other, or on one side of the room compared to the other. My favorite example of a symmetry obsession came from a guy named Mark Summers. Anybody recognize that name? Anybody? Double Dare, thank you. I'm starting to feel old because the medical students don't remember Double Dare anymore. They're all getting too young for that. But I saw there's a Dateline NBC about 10 or 15 years ago where they had Mark Summers on with his wife, and she was talking about finding poor Mr. Summers in the middle of the night arranging the tassels on an area rug. And apparently he was spending hours a night on this at the expense of his sleep and I think also his sanity. To arrange these tassels, and he was so embarrassed about it that he was hiding it from his wife. But she finally confronts him about it, and he got help, and he's actually been a really outspoken advocate for treating obsessive-compulsive disorder. But you can imagine how crippling that might be. It is possible to have an obsession without a compulsion and still make the diagnosis of OCD. So the common patterns here are intrusive thoughts, typically of a violent or sexual nature. Like somebody might say, I have this thought that I'm going to stab this person in the face and throw them out the window. It doesn't mean they want to do this. It just means the thought is there, and because it's intrusive, they're unable to consciously suppress it away and get rid of the thought, and it's very, very upsetting to them. Just as a fun trivia fact, I always like to throw in that there's an increased incidence of OCD in patients that have a first-degree relative with Tourette's disorder. Both are associated with the cingulate. And it kind of makes sense. Tourette's, some of you probably remember, is a tic disorder. And people with tic disorders actually can consciously suppress the tic to an extent, but then they're overwhelmed with anxiety and get a temporary relief when they finally carry out the tic. Much like what we've described with OCD today, where there's an obsession, they can consciously suppress the compulsion to an extent, but the anxiety becomes overwhelming and they finally have to carry it out. So the phenomenology is very similar between the two. Treatment, you're probably seeing a theme here. SSRIs again, much like we talked about with panic disorder earlier. High doses tend to be needed. Fluvoxamine also has an FDA approval for treatment of OCD. I throw this out there because a lot of people aren't familiar with this one because it has an indication specifically for OCD and not for depression. It doesn't necessarily mean it's superior to the other SSRIs. It's just an additional tool we have in a patient that might not have responded to any of the other SSRIs. Also like to remind people that if a patient with OCD has not responded to an SSRI, the tricyclic antidepressant clomipramine can be used, although we tend to prefer SSRIs as a first line because of the safety profile. As far as behavioral therapy, exposure and response prevention, and this therapy is exactly what it sounds like. So if somebody has a contamination pattern of OCD where they're washing their hands all the time because they fear they're contaminated, the therapist might have them put their hands in the dirt and sit there with it. They're going to get really anxious and they don't let them wash their hands. I know that sounds mean, but after enough exposures to that anxiety-provoking stimulus, the fear response eventually gets extinguished, and and the compulsions start going away. All right, any questions about OCD before we move on? All right, well, let's talk about post-traumatic stress disorder. First, a brief disclaimer about how the disorders are organized in DSM-5 compared to how they were in DSM-4. I still teach PTSD and OCD with anxiety disorders because that's how they've been for a long time. DSM-5 actually has put them in two separate categories. Now PTSD is in its own little chapter called trauma-related disorders, and OCD is in its own category called obsession-related disorders. They'd be kind of orphans if I didn't throw them here in anxiety disorders. So just in case anybody goes back and reads the DSM-5 after the talk today, you'll know why I put them in anxiety disorders and didn't just arbitrarily throw them in here. All right, PTSD. So we have the picture of the combat veteran here. You've probably all heard about PTSD in the context of combat veterans, and that certainly gets a lot of media attention. Please don't forget that people have all sorts of traumas that can lead to PTSD. I commonly see patients with sexual traumas, other victims of violence, victims of accidents such as motor vehicle accidents. So be sensitive to that. So the person has to experience, witness, or be confronted with a traumatic event that was potentially harmful or fatal. And DSM-5 then added that it could be from hearing about the trauma happening to a loved one or from repeated exposure to aversive details, such as with a 911 operator. And the response has to involve intense fear, helplessness, or horror. To make the diagnosis, we have to have a symptom, at least one symptom in each of 4 different symptom domains. And I stress that because a lot of clinicians make the mistake of focusing just on nightmares and flashbacks, which those are important and very distressing symptoms of PTSD, but we need to make sure we address the whole constellation of symptoms. So nightmares and flashbacks fit into the re-experiencing category. The next category is avoidance. So let's say somebody had a really bad car crash. They might avoid riding in cars. They might avoid a particular town where that accident happened. They might avoid a particular intersection where it happened. Increased arousal, another term for this is hypervigilance. Some of you might have heard. A person might survey their surroundings more intensely. A lot of combat veterans I've worked with will position themselves in the room such they can see all of the exits. So they will never put their back to a window or door because they're so afraid that a threat might enter the room from one of those entrances. Another way hypervigilance manifests as it can manifest as an increased startle response. So if somebody hears a car backfire, they might be more easily startled than somebody that doesn't have PTSD. Then there's negative alterations of cognitions or mood. So this can look a lot of different ways. Some people will just socially isolate. They have just a negative worldview, the feeling that the world is a bad place, or that the future is short, or that other people can't be trusted, marked irritability. So a number of different ways this can look. And for making the diagnosis, the disturbance has to be greater than 1 month. So for any of you that have any kind of a board exam coming up, I always stress that to students and residents, that 1 month criteria, because people that write exams like to stress the difference between PTSD and acute stress disorder. So I'll come back to that in just a second. More about treatment of PTSD. So again, SSRIs are first line treatment. The ones that specifically have an FDA indication are paroxetine and sertraline, and then the SNRI, serotonin norepinephrine reuptake inhibitor, venlafaxine. Avoid benzodiazepines. I've seen a lot of patients that come to me from other providers that have PTSD that have been treated with benzodiazepines, and when this first became a diagnosis, that was a common tool that people used, just because if somebody is hyper-aroused, well, we give them a sedative and that will bring the arousal back down. The problem is that the benefit is not maintained, so there's really not a good evidence base for using benzodiazepines for PTSD. Another problem is there's a very high incidence of substance abuse in PTSD, and because of the addictive potential of benzodiazepines, we really try to avoid benzos with PTSD. Another med that's worth knowing about is Prazosin, the alpha-1 blocker that actually was originally developed as an antihypertensive, later utilized for benign prostatic hypertrophy, and then serendipitously noticed to help with nightmares in PTSD. So a lot of times I'll have to coordinate with a urologist or a primary care physician to say, hey, you've got your patient on tamsulosin or Prazosin for their BPH. Would you mind if we had a trial of Prazosin so that we can try to dampen their nightmares in addition to treating their BPH? As far as psychotherapies for PTSD, there's prolonged exposure therapy, cognitive processing therapy, and eye movement desensitization and reprocessing therapy. At the heart of prolonged exposure is walking the patient through the aversive details of the trauma, and after enough exposures, eventually extinguishing the fear response. And this is also generally the principle that's involved in EMDR. I mentioned before there's this other diagnosis, acute stress disorder. Don't get bogged down in all the DSM criteria for this. If it looks like PTSD and it's been less than a month since the trauma, it's acute stress disorder. There are no FDA-approved treatments for this, for acute stress disorder. The important thing is to provide psychoeducation for the patient and keep a close eye on that patient to see if the symptoms persist, necessitating treatment as PTSD. Okay. The last diagnostic category we're going to look at before we move on to a few cases is generalized anxiety disorder. Let's see how I'm doing on time. So excessive anxiety and worry most days out of the week for at least 6 months about a number of events or activities. 6 months is a somewhat arbitrary amount that the DSM committee decided upon. Clinically, most of the time these patients will say, I've always been an anxious person. And a lot of times they'll endorse a strong family history of anxiety as well. Straight from the DSM, they must have at least 3 or more of the following symptoms: restlessness or feeling keyed up, easily fatigued, impaired concentration, irritability, muscle tension, or sleep disturbance. And because you notice there's some somatic symptoms in there, a lot of these patients will present to their primary care physician before they ever come to the attention of a psychiatrist. So be on the lookout if somebody is being more irritable, fatigued, and not concentrating. Ask if they've been struggling with worry. We actually have a lot of people that come in because they're saying, I can't concentrate, everybody thinks I have ADHD. And it turns out when we take a more thorough history, we find out really what they had was very severe anxiety that was not adequately controlled. Again, SSRIs are first line. Also, the SNRI venlafaxine has an indication. You can use benzodiazepines as a bridge, kind of like we talked about with panic disorder earlier. But the goal would be treating them temporarily with the benzodiazepine and then tapering them off once they've been on an SSRI for an adequate amount of time. An off-label thing that we sometimes use if we have a concern about substance abuse is hydroxyzine, also known as Vistaril. It's a histamine 1 blocker that acts basically like Benadryl. So when we have patients on our inpatient unit that are complaining of overwhelming anxiety and want something short-acting, since the SSRIs take a couple of weeks to really have clinical benefit, we can offer them some hydroxyzine for some hopefully quick relief. We'll sometimes offer propranolol, which is again off-label, but does have some evidence to support its use for the sympathetic activation that comes with an anxiety disorder. One med we haven't talked about yet is Buspirone. The old trade name is Buspar, which is not, it acts on this, it is a serotonin 1A agonist. Don't agonize over that detail. The point is it has a different mechanism from SSRIs. So there are a lot of patients who might not tolerate or might not get an adequate response to an SSRI who might actually do pretty well on Buspirone. So a lot of times when I have a patient that's had severe GI upset or sexual side effects with SSRIs, I'll give them a trial of Buspirone for GAD. Do note, though, that there's only evidence to support using this drug for GAD. It actually can worsen panic attacks and has no evidence to support its use in PTSD or any of the other disorders we've talked about today. For patients that are adamantly averse to any kind of medication, cognitive behavioral therapy has robust evidence to treat anxiety. It also is a nice adjunctive treatment to use alongside of a medication to deal with some of the negative thoughts that come along with a generalized anxiety disorder. This is a benzodiazepine equivalency chart. Has anybody ever seen a chart like this before? No? Okay. You know, and the reason I always throw this in any talk about anxiety disorders is because they're fairly commonly used, but people often don't know the relative potencies. Anytime I see somebody come to me on 2 milligrams 4 times a day of clonazepam, I'm wondering how they got on so much, because if I told you, you know, this person is on the equivalent of 32 milligrams a day of lorazepam, Ativan. They'd be like, oh, well, that does sound like a lot now that you think of it. So the biggest take home from this is clonazepam is often overdosed because people forget how potent it is. And the other thing is just to know that this exists. You can just Google benzo equivalency chart, and there are a number of reputable charts from the NIH or from the NHS in the UK. And so, like, if you're trying to detox a patient, for instance, and you want to get them to a longer acting drug, so that, let's say they're on a high dose of alprazolam, you want to detox them, you might just try to see what the equivalent dose of clonazepam or chlordiazepoxide, which is Librium, so you could change forms. All right, any questions about that before we move on to a couple of cases? All right, well, this is where I'm going to ask for some interaction from the live audience here at St. Vincent's East. So 34-year-old male presents to primary care with a complaint of long-standing worry. He reports this as being a problem since childhood, but it has been more impairing over the past 8 months since he started a new job. He notes worsening insomnia, muscle tension, and difficulty focusing at work. What's the diagnosis? GAD, great, slam dunk. So what treatment would you like to offer? So you could do an SSRI. Any other possibilities? Did I hear a Buspirone? Yeah? Yeah? CBT, great. Everybody's paying attention. But, you know, let's say you chose sertraline, also known as Zoloft, 50 milligrams, which is the starting dose in the PDR. 4 weeks later, the patient reports modest benefit, but complains of sexual side effects. What are our other options? So you could change SSRIs. That's one option. Did I hear a Buspirone out there? Yeah. So, and then the other option is that if the patient says, I'm done, I don't want any more meds, then you can make a referral for cognitive behavioral therapy. Great. So I think y'all have mastered GAD. All right, next case. 26-year-old female patient presents to primary care with a complaint of multiple episodes of heart palpitations, shortness of breath, and sweating. She reports she felt like she was about to die. Twice she presented to the ED and had a negative cardiac workup. Over the past few weeks, she's been skipping many of her lectures for her grad school program because she's afraid she will have such an episode and feel trapped. I heard panic disorder. We have, everybody concur? So we got panic disorder. So what are our options? SSRI, heard SSRI, so yeah, that's a good option. Would we consider bridging with the benzodiazepine? Maybe, yeah. I mean, that's where you need to make a clinical judgment. If you know this patient has a long history of substance abuse, maybe not. But again, that's just, you also have to make a judgment of how impairing is this. Can they afford to wait a few weeks while the SSRI takes effect? So again, that's up to clinical judgment. So we talked about SSRI, bridging with benzodiazepines. You could consider an SNRI, and I sometimes see people respond better to an SNRI. Physiologically, it doesn't make sense, but actually at low doses, SNRIs like venlafaxine or duloxetine, also known as Cymbalta, actually work like SSRIs. So the higher doses actually get you to the norepinephrine range, which tends not to give you any additional benefit for panic. But at the lower doses, they will basically function like SSRIs. Does Buspirone have a role here? No, Buspirone does not help with panic disorder and actually might worsen the symptoms. Sometimes we'll use propranolol off-label if we have a patient that's not appropriate for a benzodiazepine, but we want something that will help dampen the sympathetic symptoms of a panic attack while we're waiting for the SSRI to take effect. All right, so you start the patient on sertraline, titrate up to 100 milligrams over 2 weeks. At 6-week follow-up, her panic attacks are less frequent, but she still reports 2 attacks per week. What now? Increase the dose. And I put this in here deliberately because a lot of people are afraid to push the dose, just like, God, 150, that sounds like a lot. It's really not, and one of the things I was taught was milligrams don't matter. And this was by one of my colleagues at UAB who actually participated in the clinical trials for sertraline a number of years ago. And he was saying the FDA maxes are really set so that they can get the drug through the approval process. But really what you need to do in clinical practice is if they have a partial response, you titrate either until you achieve adequate clinical benefit or you get to side effects. So don't be afraid to push. If they're getting benefit with each successive step, try pushing the next one up, and don't be afraid to get somebody to 200, 250 of sertraline. All right, any other questions about that one before we go to the last case? All right, last case. 52-year-old female patient presents for care 3 months after being the victim of a sexual assault. She complains of nightmares several times a week. She reports that she feels paranoid and is always looking around at men around her, wondering if they might be a danger to her. She also has been avoiding males in general, which has been problematic in her workplace. She socially isolates and rarely goes out with friends anymore. So what's our diagnosis? PTSD. That's an easy one. So treatment options. Yeah, so I heard so Prazosin for the nightmares, and I heard Zoloft, sertraline as an option. Again, the other ones that have the most evidence, paroxetine, Paxil, and venlafaxine, also known as Effexor. So we've covered our SSRIs, our SNRI that has an indication. We've got the Prazosin for nightmares. We sometimes will also use Trazodone to help with sleep. Prazosin is great for nightmares, but doesn't have necessarily the sedating effect that some patients need to get to sleep in the early stages of PTSD. Trazodone, which is an old antidepressant, at lower doses is commonly used as a sleep aid in psychiatry. So don't be afraid to use 50 or 100 milligrams of Trazodone to help a patient sleep. A few patients will report a worsening of nightmares. So be on the lookout for that, but don't be afraid to use Trazodone to help these patients get some sleep. The good thing about Trazodone is it's non-addictive. Most of its sedating effect is really just from blocking the histamine receptor, much like Benadryl. What do you make of her paranoia? So that's an interesting thought. The reason I bring this up is I've seen too many patients that are misdiagnosed as having a psychotic disorder when they say that they're paranoid, when what they really have is really awful, awful PTSD. And so when they say, if somebody says, I feel paranoid, that doesn't always mean they're psychotic. You need to ask them more about what situations do you feel paranoid in? What thoughts do you have? And if they say, well, when I look around and I see all these men, I see them looking at me and I think they might be coming to hurt me in some way. That's hypervigilance. That's part of PTSD. There certainly are some patients with PTSD that do end up having some psychotic symptoms, but the case that I described, that's not psychosis, that's severe hypervigilance, and we should treat it as PTSD. Okay. All right. So I think we have time for just a couple of questions, if anybody has questions about those. Yeah?
Are there any changes in the therapy, especially with the duration of therapy, if any of the anxiety disorder is associated to an anniversary event?
Oh, that's a great question. So the question was if there are any changes to the therapy when the PTSD is associated with an anniversary event. And there's really I don't personally know of any literature specifically on this, and there certainly isn't anything that has the level of a formal FDA indication. For my patients with PTSD, I try to just schedule closer sessions when an anniversary date is coming up. And for those of you in primary care settings, that's perfectly appropriate too, just to have them in contact with a trusted healthcare provider when you know that this difficult time is coming up for them, just so that you can help them process this and make sure that they're not deteriorating. There are some patients I worry about having suicidal ideation when they get close to the anniversary of a trauma. And I always talk with them and say, would you like to come in a few days before and then a few days after so that we can check in? And most of the time they're very appreciative that I have brought that up for them.
Have you had any patients with intrauterine death of a baby?
I have not personally, but I certainly have heard of cases, and I know that that's, I think that would fall into a similar kind of case as this first question, where I imagine anniversaries are particularly painful. For those kind of patients, I start with grief counseling because it's a death. And those patients tend to go through a similar process as what people go through when they lose a loved one. Most patients with that, I would expect to not necessarily have the PTSD symptoms of the hypervigilance and the avoidance like what somebody who's been through an assault might experience.
Talking about at the time of delivery also?
So, I mean, that certainly could be, that could end up being a trauma. Like, let's say the woman thought that the pregnancy was going normally, and they end up unexpectedly pulling out a dead fetus, or there is a gory complication with that. That definitely could precipitate the development of PTSD, and it would just be appropriate for the obstetrician to make a referral to a mental health professional to monitor the patient and see how she's doing with that. Yeah. Anything else before we wrap up? All right, thank you all very much for your attention.